Hello, this is Walter Mack, and today we will be describing and outlining an approach to interpreting hip MRI. You're going to see sequences from both a hip MRI arthrogram and a conventional MRI, and I just want to make a brief comment about protocoling a hip MRI. I think a lot of it is dependent on what the clinical question is, because parameters, particularly field of view, become very important. We want a focused, smaller field of view if it's a dedicated labral assessment or cartilage assessment. For example, if the query is for assess for features of femoris impingement. However, if it's a more kind of vague hip pain type story, or assess lesion, look for METs, or assess for avascular necrosis, or assess for trochanteric bursitis, and we may benefit from expanded coverage and increase the field of view to ensure that we allow for adequate assessment of all the periarticular structures. But of course this would then compromise evaluation of the acetabular labrum and cartilage. So I like to begin my interpretation of the hip by looking at the labrum and then looking at the cartilage of the right hip joint in this case, and then I look for impingement features, and we'll go over what to look for with respects to femoral impingement. And I tend to routinely look at these features, even though many of the cases that you look at, hip impingement won't be a relevant consideration. So I tend to look at it. I don't always report it, or I don't always make it a focal point of my impression, but I think for the purposes of this talk it would be relevant to include a few comments on hip impingement. And so having looked at all that, then I look at the regional tendon attachments, and we'll go over all of those, particularly since it tends to come up on OSCEs a lot. And then the regional musculature, look at the marrow signal, and then we start looking at the corners of the film, like the right SI joint. Sometimes you get just a little bit of the SI joint, and then usually you guys tell me if there's something going on in the adnexal regions or pelvis that warrants further investigation. So the two sequences you see here are actually from a hip arthrogram, and these were acquired as a 3D turbospinacal acquisition, so we have thin sections, and I think these optimally demonstrate the acetabular labrum. So think of the labrum as being an inverted horseshoe. So here is the superior labrum, and as you recall from your experience with shoulder MRI, the normal labrum should be triangular in shape. Rounded is okay. Notice how this one's a little rounded, and it should be homogeneous, low signal in signal in all sequences. This is an oblique axial sequence, and this tends to be an advantageous imaging plane for assessing the hip labrum, because then it puts the anterior and posterior labrum in profile, so your images are going perpendicular through the anterior and posterior labrum, and it makes assessment of these regions of the labrum much easier. You may be at a site where they actually do radial imaging. We don't do radial imaging at St. Michael's, but if you are reading an MRI that includes radial imaging, what I strongly suggest that you do is that you put up the sagittal sequence while you're looking at the radials, and the radial images will tend to kind of go like this. And if you have the sagittal as sort of a localizer, then I think that will help orient you, and I think those radials can be useful if you go through that exercise of orienting yourself, particularly at the corners. So the anterior superior corner, posterior superior corner, this is where your orthogonal coronal and axial images may not show the labrum optimally. Okay, so thankfully most labral tears tend to happen in one quadrant, in the anterior superior quadrant. So if we see that we've lost that nice black triangle, this is a sagittal sequence obviously, if we've lost that nice black triangle, if it's fissured, if it's diminutive, if we see fluid signal or contrast signal cleft extending into the labrum, then we can reliably diagnose a labral tear. Of course, in the postoperative situation, then we must be cognizant that a diminutive labrum, a diminutive appearing labrum, is not simply a sequelae of previous surgery. Hopefully that history will be provided to you. Just like in the shoulder, also look for paralabral cysts that may be a more conspicuous sign of an underlying labral tear. And then there's the whole question of variance. So we spent a lot of time talking about variance in the glenoid labrum in the shoulder, and there is one major variant. It's called a sublabral sulcus, and unfortunately it's been described in all four quadrants, so anterior superior, posterior superior, anterior inferior, posterior inferior. I tend to only call it when I see it in the posterior inferior quadrant. That's where it's most commonly recognized, and it will be a smooth, thin cleft. It will not go through the entire base of the labrum, so this here is the base of the labrum. It would just kind of undercut the labrum slightly and not go all the way through. But if you see something similar in one of the other quadrants, it may well be a sublabral sulcus, and then that's where you would just have to make your best determination. Moving ahead, some might wonder, well, do we use a clock when we're describing labral lesions like we do in the shoulder? I think some people do. I tend not to, again, because of the oblique orientation of the labrum. I think it gets confusing, and I think we're doing good enough if we are able to tell our referring clinicians which quadrant the suspected labral pathology is that we see. So what I tend to do is I tend to describe labral lesions in terms of the anterior superior, anterior inferior, posterior superior, and posterior inferior labrum. The sagittal sequence is pretty good at showing lesions in the anterior superior and even in the superior labrum. I like this oblique axial once again for the anterior and posterior labrum, and if we go to a straight coronal, that also shows quite nicely the superior labrum as well. Note that there is no quote-unquote inferior labrum, so if we pull up that sagittal sequence again, here we are. So this quote-unquote inferior labrum is actually the transverse ligament, so I just want to point that out. And also we'll just point out one other structure while we are here. So this here is the Ligamentum teres, okay, leading into the fovea capitis of the femoral head, and in the pediatric population this actually transmits vascular supply to the femoral head, not so in adults. So we assess the whole labrum, we document in tears, we describe the tear morphology. It can either be just a tear, it could be contralabral separation if you see that the labrum is completely detached. It could be a complex tear if it's macerated or diminutive, and then whether or not there's a perilabral cyst as we described. And then I start looking at the articular cartilage, which is nicely shown in these 3D sequences. And thankfully you assess cartilage in the hip much like you do in the knee. So if I see signal heterogeneity, then I'll call that mild chondrosis. If I start seeing thinning of articular cartilage, then I'll either call it moderate. If it's, some people like to grade their cartilage, so once again, if it's mild chondrosis, grade 1. If you see thinning that is perhaps less than 50% of the thickness by your estimation, then you can call that grade 2. More than 50%, grade 3. And then when we start seeing bone changes, so marrow edema, so that of course we would better see on a T2 weighted sequence like this one here. We start seeing marrow edema or subchondral cysts, and that's good evidence that we have full thickness cartilage loss in that location, and that some might describe as grade 4 chondrosis. So I also like to give an indication as to whether it's focal or diffuse, and that you'll find that assessing the hip cartilage is a little more difficult than the knee because the cartilage surface tends to be thinner, but in general, it's doable with careful analysis. In general, it tends to be the acetabular cartilage that will thin out first, but as you can see, unless you're at a site that does traction arthrography, and I don't believe any of the Toronto sites do traction arthrography, it can be hard to resolve with your eye the cartilage surfaces of the acetabulum and the femoral head as discrete layers. So you have to just kind of look at it and give it your best shot. So we've looked at the labrum, we've looked at cartilage, and now let's start talking about impingement features. And I don't want to make this an exhaustive discussion about femoral impingement, so we're just going to quick and dirty go over what we look for on a routine basis. So I use the oblique axial sequence. If you have a 3D acquisition, you can reformat your sequence to this plane, or if you have radials, then you can also look at look at hopefully there'll be a sequence that will show you this perspective as well. And I first look for loss of head neck offset at the anterolateral femoral head neck junction. And so I just kind of scroll up and down, and you see how there's this preserved concavity here. So subjectively, it looks like there's no loss of, there's no bony bump, there's no loss of head neck offset. That's one way to do it, and that's how I tend to do it most of the time. There's an official measurement that one can do, and that's the alpha angle. And how do we do the alpha angle? So what we do is we draw a circle approximating the femoral head. So this is very approximate. Okay, and then the angle is formed by two lines. The first line goes parallel to the femoral neck, and it goes right to the midpoint of this femoral head. And you draw the second line where the bone of the femoral head leaves the circle. So here we are following the circle, and I would say around there it leaves the circle. You can see that here now the bone is starting to leave that circle. So we're getting a measurement of 52 degrees, which is kind of upper normal. Depending on whatever source you refer to, some quote 50 degrees as the upper limit of normal, some quote 55 degrees. I tend to use 55 degrees. So this one I would probably read as negative for a cam deformity. Before I forget, I just want to mention that a lot of people are walking, myself included, are walking around with these impingement features, and we don't necessarily have impingement. So remember that hip impingement is a clinical diagnosis, and we're simply assessing for features that may predispose a patient to impingement. Also, one may not have any of these features of impingement, yet may clinically present with hip impingement as well. So not having the features does not preclude the clinical diagnosis either. Okay, so that's the alpha angle. Now to look for features predisposing to quote-unquote pincer femoral impingement, we can look at the straight axial sequence. So this is just a straight axial sequence here. And what I do is I scroll up and down, and generally it'll be near the top of the data set here. So this is the superior acetabulum. And I ask myself, at any point, does the anterior wall of the acetabulum protrude lateral to the posterior wall? And if it does, that's abnormal, and this would then be the cross-sectional correlate to the crossover sign that you may have learned at radiography. Here doesn't look like the anterior wall ever gets convincingly lateral to the posterior wall. If you only look down at the kind of equatorial level or below, the anterior wall of the acetabulum, I can assure you, will always be medial to the posterior wall, and everyone is normally anteverted at this point. So you really, to pick up this retroversion of the acetabulum, you really have to look up high. Another thing you can do is go back onto that oblique axial sequence and draw a line kind of connecting the anterior and posterior acetabulum, and this should stay medial to a midpoint of the femoral head. So if for example this patient's anterior wall came out way out like so, then this line would be lateral to the midpoint of the femoral head, and then we would then describe acetabular retroversion predisposing to hip impingement. Okay. So we've talked briefly about the labrum, we've talked about articular cartilage, we've talked about impingement features. Before I leave the MR arthrogram, I just wanted to point out one or two potential pitfalls. Here's one right here. So here we're going to talk about muscles and tendons later, but here's the iliopsoas muscle, and recall that the tendon is eccentrically located at the posterior medial aspect of the muscle. So this is the iliopsoas tendon, and you can imagine then if I consider the composite of the anterior labrum and this iliopsoas tendon as one structure, I may erroneously diagnose a labral tear, when in fact it is simply the interface between the iliopsoas tendon and the anterior labrum. So that's one pitfall that comes immediately to mind. Another pitfall is that you may see apparent defects in the superacetabulum, and these are supraacetabular fossa, and then more medially a stellate crease, or supraacetabular, I think, crease, I think is what they call it. And I think it's just a matter of seeing one or more of these to learn how to distinguish these from true osteochondral lesions of the hip, which are not nearly as common as those in the knee. You can see that on this dedicated hip arthrogram protocol, in this case we actually do see a fair number of the regional tendons and muscles, but there may be other cases where it's much more focused and you actually miss out on the trochanteric region, for example, or you don't see all the hamstrings, as is the case here. So once again, very important to tailor the MR examination to the specific clinical question, and unfortunately some or a lot of this depends on the referring clinician providing us with adequate history as well. But I think that's a discussion for another day. So now let's go and look at our routine protocol MRI. Here it is. Okay. And so having looked at the labrum, cartilage, and impingement features, now we're on to what I would consider the easier, quote-unquote, easier stuff. And I assume that you've already have some experience in shoulder and knee MRI. And one of the beautiful things about MSK MRI is that it's actually the same things over and over again. So how we assess muscles, tendons, and ligaments in one joint is exactly the same as how we assess them in another joint. So in general, tendons, for example, if we see that they've lost their normal homogeneous low signal and instead they're intermediate in signal, we might call tendinosis. If we see fluid signal, then we'll call teres, and we'll start asking ourselves, well, is this a partial tear, or is this a complete tear or full thickness tear involving all of the tendon substance? So the next subsection here, I'm really going to focus on just pointing out where all these structures are, and then we would apply a similar analysis as you would for tendons in the knees and above the shoulder to interpret the integrity of these structures. So let's just start with the iliopsoas, since we had already mentioned it in passing in the arthrogram section of this. So here's the iliopsoas, here's the iliopsoas. I'm going to just blow this up a little bit. Here's the iliopsoas tendon, again eccentrically located at the posterior medial aspect of the muscle belly, and as you guys know, it inserts on the lesser trochanter. You may sometimes see joint fluid extending into the so-called iliopsoas bursa, and if you do have iliopsoas bursal fluid, it's going to encircle the iliopsoas tendon, and notably, technically, a component of the fluid should extend medial to the tendon in order for you to be able to call it iliopsoas bursitis, because I've seen mass lesions actually mimic iliopsoas bursitis. So make sure that anatomically what you're calling iliopsoas bursitis fits. We're going to swing out laterally now, and let me just pull up a sagittal sequence, and we're going to talk about the gluteal tendons. So if we go to a far lateral sagittal image, here is the gluteus minimus tendon, alright, inserting on the anterior facet of the greater trochanter, and notice that there is a bit of an oblique orientation of that muscle and tendon. So this is important to realize and to remember. If you were to do a gluteal tendon ultrasound, for example, you have to place that transducer slightly oblique coronal to get that gluteus minimus in parallel with your transducer. If we scroll slightly more lateral still, we're going to see components of the gluteus medius tendon. Okay, so the gluteus medius tendon has two broad insertions. It will insert upon the, let me just change the format here. Good. It will insert upon both the lateral facet, so right here, as well as the superior posterior facet of the greater trochanter. So to review, gluteus minimus and medius both insert onto the greater trochanter, as you can see here, and then gluteus maximus actually inserts more inferiorly along the posterior aspect of the proximal femur along the linea aspera. So keep in mind that the different tendon attachments, once again, if we see intermediate signal, we'll call tendinosis. If we say high signal, then we're going to start calling tears, either partial or complete. And if you see a complete tear, then I would also assess the muscle belly. So gluteus minimus is more medial, gluteus medius more lateral, and look for fatty atrophy or denervation. Alright. Let's talk about the bursae about the hip, about the trochanteric region. So we talked about iliopsoas bursa already. There are actually three discrete bursa in the trochanteric region. And when people say trochanteric bursitis, they really mean the subgluteus maximus bursa. So here's the gluteus maximus muscle, and subgluteus maximus bursal fluid or trochanteric bursitis would tend to collect between that greater trochanter and just deep to the gluteus maximus muscle, so it'd be in here. If you see fluid deep to the gluteus minimus tendon, then that's subgluteus minimus bursitis. And if you see fluid deep to the gluteus medius tendon, that's subgluteus medius bursitis. Alright, so a lot of these conditions happen concurrently, so you may have tendinosis and bursitis of one or more of these gluteal tendons. Keep in mind too that you can also have calcific tendinitis or calcific tendinosis of the gluteal tendons, just like you may in the shoulder. And there are actually a lot of parallels between the gluteal tendons and the rotator cuff tendons, and indeed some have likened the trochanteric region as, or the gluteal tendons as, the rotator cuff of the hip. So we've done the iliopsoas, we've done the gluteal tendons. Next I'll point out the rectus femoris tendon. So this is the direct arm coming off the anterior inferior iliac spine. We might see this as well on the sagittal sequence. Alright. Once again, don't be afraid to use the localizer. I think especially when you're starting out, it really helps orient you to the anatomy quite nicely. So this is the direct arm of the rectus femoris coming off the anterior inferior iliac spine. And you look really carefully, there's this other guy that comes off slightly more posteriorly. It's this curvilinear guy right here. Okay, and this is the indirect arm, and so you can actually have isolated injuries of either the direct arm here or the indirect arm here. I think when you're just starting out, and in a majority of cases this won't be relevant, but once in a while it will be. So the indirect arm, I believe, forms the aponeurosis around the muscle, and the direct arm forms the central tendon here, and so this is the rectus femoris muscle more inferiorly. And as we scroll through now, we will talk about the hamstring tendons, and this I think is an OSCE favorite as well. So there are two discrete tendons that come off the ischium here. So the deeper, more lateral one is the semimembranosus, and then not shown well, unfortunately, here, the more superficial medial tendon is the conjoint tendon, which will eventually give rise to the biceps femoris as well as semitendinosus muscle. If they give you an image like this, where you're just distal to the hip and there's one muscle here, that is going to be the semitendinosus muscle. Just remember that the semimembranosus muscle you see down by the knee, just above the knee joint on your knee MRIs, and at that point you have a smallish subtendinous semitendinosus tendon line just superficial to the semimembranosus muscle, and it's the opposite situation here where you see the semimembranosus tendon and just the semitendinosus muscle right there. And also note the sciatic nerve, which is just lateral, as well as the quadriceps femoris muscle here. Alright. If we are to assess the individual hamstring tendons, I think sometimes using the coronal sequence is helpful. Here, again, not terribly well shown, but I would argue that this is probably the semimembranosus. Here it's more lateral, and then this is the conjoint tendon. This conjoint tendon looks a little heterogeneous to me. It looks a little intermediate in signal. So this is one I would be tempted to call tendinosis here with regards to the conjoint tendon. The quadriceps femoris muscle is important to look at for a couple of reasons. One, it's a great landmark for the sciatic nerve, so it's immediately deep to the sciatic nerve. It's the most inferior of the so-called deep external rotators. So so this is a far posterior coronal image, and it's all these guys here. So your gemellus muscles, obturator externus, and quadriceps femoris. These are collectively known as your deep external rotators. And then of course there is also the entity known as ischiofemoral impingement. Alright, where patients can have this kind of vague posterior hip pain, and it's a consequence of this quadriceps femoris muscle being pinched between a narrowed space between either the ischium and lesser trochanter, so this space here, the ischiofemoral space, which should be no more than 15 millimeters, or the quadriceps femoris space, which is, I believe, the distance between that lesser trochanter and the hamstring tendons. That should be no more than 10 millimeters. Here, not relevant, because here this looks quite capacious to me, but that's something that might be worthwhile looking for if you see isolated edema or atrophy in the quadriceps femoris muscle. So moving right along, now we're just kind of going by process of elimination here. There's actually, or there should be, a dedicated protocol performed if the query is osteitis pubis, athletic pubalgia, sportsman's hernia. That actually shouldn't be a hip MRI at all, but it should rather be a focused MRI centered on the symphysis pubis. But unfortunately, sometimes you get a vague history, and also unfortunately, on a conventional field of view MRI, you do tend to see enough of the adductor tendons and origins that I think if there's an abnormality there, it should at least be commented upon, and the reader should be directed to pursue a dedicated parasymphyseal MRI. So to my knowledge, there's no easy way to remember all the adductor tendons and muscles here. So going from superior to inferior, the most superior one is going to be pectineus, and then as we scroll more inferiorly, it's just going to be adductor longus, brevis, and magnus. Longus, brevis, magnus. And again, sorry, I don't have an easy way to remember that, but I wouldn't be surprised if on the next OSCE you get this, and then they go ahead and label all this stuff here. So longus, brevis, magnus, and pectineus, the highest one up here. And also the anterior and posterior divisions of the obturator nerves will separate the longus from the brevis and the brevis from the magnus. Looking for athletic pubalgia. Basically, this is a chronic overuse injury of the rectus abdominis, adductor longus musculoaponeurotic unit. So we're essentially looking for disruption of the adductor longus tendon at the attachment to the pubis. Okay, so you'll see kind of a fluid signal cleft where you would expect the adductor longus to attach, or you might see adductor longus tendinosis, or you might see tear. Occasionally you actually get a complete or acute tears of the adductor longus tendon with distal retraction. Those look like tendon tears elsewhere. And also it's important to assess the rectus abdominis insertion onto the pubis as well. This patient looks like they might have some degenerative change along the synchondrosis of the symphysis pubis, and also look for stress fractures of the pubic bone, which may also mimic clinically findings of athletic pubalgia. Okay, so we've done the hamstrings, we've done the gluteals, we've done the iliopsoas. We talked briefly about rectus femoris and the adductor tendons. This is just for completeness. This is the tensor fasciae lata muscle. It comes off the ASIS as well. This is actually the iliotibial band. All right. So we think of the iliotibial band as down by the knee, but here it is. And some patients can actually have so-called proximal iliotibial band syndrome. I don't tend to make that diagnosis too frequently, but it is out there. The sartorius is easy to localize because it's the muscle that's going to overlie as we scroll from superior to inferior, the femoral vasculature. So it's this guy diving in here, and then on some studies you may actually start getting into the quadriceps musculature. So we said this was rectus femoris, and then this will be vastus lateralis. You're going to see vastus intermedius coming off, and then vastus medialis more inferiorly. Alright, so in this brief tutorial we looked at the hip labrum, we looked at cartilage, we talked briefly about impingement features, we looked at cartilage, and then we looked at the regional muscle tendons and muscles and tendon attachments, and now we're almost done. Now we just have to kind of go through the corners of the film. Alright, and again, you not infrequently get just enough of the SI joints such that if there were pathology there, it may show on your study. So you can imagine, for example, if we have a young patient with undiagnosed hip pain, quote-unquote hip pain, and in fact it's actually low back pain, and they have inflammatory sacroiliitis, you might actually see some features of that there. And of course, you won't see it well enough to make the diagnosis, but you will see it well enough to be responsible for at least noting it and directing the clinician appropriately. Since we are fairly proximal in the appendicular skeleton, I think as you do more and more of these cases, it's helpful to just get a feel for what red marrow looks like. You can see a lot of red marrow, and you should always ask yourself whenever you see heterogeneous marrow, is this plausible for red marrow? Is what I'm seeing plausible for red marrow? So let's just kind of go through this chrono T1 sequence and ask ourselves if that's the case. So we see some marrow heterogeneity, and it looks a little bit darker here in the intertrochanteric region, proximal metaphyseal region. Notice how also, when we go to the greater trochanter, which is an epiphyseal equivalent, we actually see just bright fatty marrow. So this is all yellow marrow. And when we look in the capital femoral epiphysis here, nice yellow marrow, so it's bright. And so we see this marrow here, and we ask ourselves, is it darker than muscle? No, it's not. And then we should ask ourselves, is it in a plausible location for red marrow? Yes, it is, because in fact, in the long bone, the proximal metaphysis is the very last spot for red marrow to convert to yellow marrow, and also it's the first spot to reconvert to red marrow in times of stress, when the body has to kind of rev up those red blood cell producing factories once more. So seeing red marrow in the proximal femoral metaphysis is not unusual at all. So this is a kind of analysis that over time would just take a couple of seconds, but if you're just starting out, the heterogeneity of the marrow may surprise you quite a bit. And then once again, because we are radiologists, also look at what we see of the pelvis, and I'll grant you we often don't see much of the pelvis, but you might see, the thing that I worry about the most is adenopathy and adnexal masses, and so on and so forth. And of course, as is true for most MRIs, if the tech goes ahead and sends you a localizer image, then I strongly encourage you to look at that localizing image, particularly since you may see pathology outside of the field of view of the diagnostic sequences. For example, we often do hip MRI looking for AVN, and it's easy enough to spot on the side in question, but the localizer might actually show findings of AVN on the contralateral side as well, and that may or may not be known, so good to look there as well. Alright, so I hope you found this helpful. You all know where I live and how to get in touch with me if you have any questions or concerns, and of course, as always, I'd appreciate any feedback that you may have. Thank you very much.